Please start, sir. We are live.
Good evening, everyone. I welcome you all for today's webinar on recent advances in Biliary cancer update. With immense pleasure, I would like to invite Dr. Asif Khan, who is consultant medical oncologist in AIG Hospital, Hyderabad, for welcome introductory note. The stage is all yours.
Oh, thank you, Vishal. I'm Arif Khan here. So I take this pleasure to invite you all for this conference. So basically, this meeting we are going to discuss about hepatobiliary cancers, starting from the clinical presentation and also the recent developments which we have seen in this hepatobiliary cancers. So a lot of things have changed in this advanced hepatobiliary cancers. Previously, we did not have much options. Now we have got immunotherapy in the advanced HCC. It's slowly moving into the locally advanced HCC. So HCC basically we know it's a difficult to treat cancer, and it involves a multi-modality management. So all interventional radiologists, hepatologists, oncologists, surgeries, liver transplant surgeons, radiation oncologists, everyone come together and treat these hepatocellular carcinomas. So we are going to discuss the basics, how they present, and what are the newest advances in this space. Without further delay, I would like to invite the first speaker for this session. Here, Dr. Jatin. He is a consultant gastroenterologist and a hepatologist at Apollo Hospitals, Jubilee Hills, and he will be presenting about the clinical presentation of hepatocellular carcinoma. So, Dr. Jatin, over to you. Is Jatin there?
Yes, sir.
Jatin, over to you.
Yes. Just a minute. The slides visible?
Yes.
So good evening, everyone. Thank you for inviting me for this meeting. So today we're going to start off with the discussion on the epidemiology and the clinical features and parts of diagnosis. So coming to epidemiology, we know that the HCC is one of the most common cancer that is responsible for cancer-related deaths. And if we look at the recent Globocon data of 2022, so it's the sixth most common cancer, and it's because of its advanced presentation at its advanced stage and aggressive nature. It has a very poor prognosis, and it is the third highest cause of cancer-related deaths. So the overall prevalence, the incidence of HCC in cirrhotics is around 1.6% every year. And if you look at the global incidence, it is around 4.3. It contributes to 4.3% of all the cancers that are diagnosed. So most of the times, more than almost half of the times, the liver cancer, by the time they have presented, it must have already spread to the lymph nodes or metastasized, and hence the prognosis remains poor. Early diagnosis remains the key, and hence a stringent screening strategy with ultrasound or alpha fetoprotein. And sometimes, if the ultrasound is not reliable or fallacious, we can go for a triphasic CT to diagnose the liver cancer. So, early diagnosis remains the key for successful management of liver cancer program. So, coming to Indian data from the global data, if you look at the INASL paper which talks about the epidemiology in India, it is the 11th most common cancer and 8th most common cancer related death. And among the men, it is second most common cancer leading to death. It has a male preponderance with the ratio of 4:1, and incidence increases with age. And median age of presentation is 40 to 70 years. And as I said, 1.6% per year is the incidence of HCC in patients who already have cirrhosis. So, at what stage the patient present at the time of diagnosis? So, looking at the AIMS data, 40% of the patients present with half of the patients present with PCLC A and B, and half of them with advanced. So among the first half, we are able to diagnose only 12% of patients in the very early stage of BCLC A, and 40% of them, which is the majority, are diagnosed in the stage of BCLC B, and rest half in the BCLC C or D. So what are the risk factors for HCC? We all know that patients without cirrhosis can also develop hepatocellular carcinoma, and hepatitis B is one of the most common cause of that subset. But nowadays we are seeing even patients with hepatitis C and NAFLD patients also developing HCC without progressing to cirrhosis. And all the etiology of chronic liver disease, once they lead to cirrhosis, it puts the patient at higher risk for hepatocellular carcinoma. So if you look at the proportion of HCC etiology that has changed in the last 30 years, initially hepatitis B was contributing 53%. However, now it has shrunk to 42%, and the major shift is noticed in the NAFLD component and hepatitis C component, leading to development of HCC. So hepatitis B, because of the effective antivirals and NA therapy, we are able to suppress the virus and and also reduce the incidence of hepatocellular carcinoma related to hepatitis B alone. So if you look at the etiology fraction in India with or without the background of cirrhosis, so this shows that the most common etiology is NAFLD, and followed by hepatitis B or C, and sometimes even alcohol also can cause HCC without cirrhosis. So, coming to the clinical presentation, patients, whenever most of these patients, when they present with unresectable HCC, when by the time that they have developed any symptoms. So usually symptoms are seen in advanced patients, and these include weight loss, right upper quadrant pain, or a palpable mass. And patients also have a lot of weight loss, anorexia, fatigue, and non-specific symptoms. And the typical manifestations of liver cirrhosis decompensations are also could also be a indication of patient developing HCC. So when you have a patient with any new onset decompensation without any specific trigger, then always get a triphasic CT to see if the patient has developed any portal vein thrombosis or HCC. And we all know that HCC also has a lot of paraneoplastic syndromes, and the patients can present with one of the most common paraneoplastic syndrome is the hypoglycemia, and the other paraneoplastic syndromes are erythrocytosis, hypercalcemia, hypercholesterolemia, and carcinoid syndrome, and changes in the secondary sexual characters, which are seen even in patients with cirrhosis. Coming to the diagnosis part, we begin with the classical basic investigations like ultrasound, and we proceed to either CT or an MRI. We typically order a triphasic CT where we see the classical characteristics of hepatocellular carcinoma, and usually CT is sensitive to characterize a lesion which is at least a centimeter in diameter, and LIRAT's scoring can also be applied, and subsequently the patient has to be evaluated regarding the etiology of the liver cirrhosis or the HCC, the risk factors, their nutritional state, performance status, and amenability for the curative options. And in order to classify the patients into BCLC, we need to get their routine blood chemistries, liver test, INR, and tumor markers, which include AFP and PIVKA2. So try sometimes if we are not able to characterize well with one of the imaging modalities, we may have to go for another imaging modality, that is triphasic MRI. If there is discrepancy, or if we are not able to establish that classical characteristics of HCC on two imaging modalities, that is the time when we usually go for biopsy. And with the advancements in imaging characteristics, the non-invasive diagnostics have been the standard of care in the last 2 decades, prior to which the biopsies were the mainstay for diagnosis. So the classical features of HCC are arterial phase hyperenhancement and followed by immediate washout. And there are other features like lesion encapsulation, enhancing capsule, and if there are interval imaging, then the growth of the tumor can also contribute to the diagnosis of HCC. So similar to BIRADS, we have a LIRADS classification where LR5 means it's a definite HCC and LR4 is probable HCC, and LR1 is a definitely benign lesion and LR2 is probably benign. So these LR classification is based on the whether the patient has any arterial phase hyperenhancement, whether it is non-rim enhancement, what is the size of the lesion, and whether the patient whether the lesion has enhancing capsule and washout. So biopsies are usually not done, but in patients with non-cirrhotic HCC or inconclusive on two imaging modalities or prior to immunotherapy, usually we do a biopsy. And uh, so, as I said before, the routine blood chemistry, we classify the patient according to the child pug status into A, B, or C, with whether the patient has preserved liver function or advanced liver disease. And also the quality of life has to be taken into account. ALB scoring is also done using bilirubin and albumin. So this is the BCLC updated classification where the HCC is classified into very early stage, early, intermediate, advanced, or terminal. If we just go through the classification system, it takes into account the size of the lesion, the number of lesions, whether the liver function is preserved or not, and the performance status. And very early stage is a stage where the lesion is just less than 2 centimeters with a preserved liver function. If the patient is a potential candidate for liver transplant and with the portal pressure being elevated, then if the patient does not have any contraindication, he has to be offered a liver transplant as a curative option, and which will take care of both the HCC as well as the liver cirrhosis part. And if the patient has any contraindications for liver transplant, we can offer him ablation, and which can be either be radio frequency ablation or microwave ablation or IRE. And if the patient has normal portal pressure, then and a single lesion which is less than 3 centimeters or 3 centimeters, then we can offer the patient curative resection. And if the patient happens to have multinodular HCC, and if the number of lesions is less than 3, each measuring less than 3 centimeters, then if the patient does not have contraindications transplant, then we should offer him transplant. And if the patient has contraindication, then we can offer him ablation for multifocal also if it is less than 3. If the number of lesions is more than 3, then we can apply the extended liver transplant criteria, and we can try to do a transplant. However, it is very large and diffuse infiltrative bilobar involvement, then we have to start off with a systemic therapy. And if the patient has well-defined nodules and preserved portal flow, then we can do local regional therapy, which is TACE, or if it is close to the portal vein, we can do a tear. And among the patient, among systemic therapy, now we have immunotherapy, which has become the first line of therapy. I think the subsequent discussion will be regarding the immunotherapy and emerging modalities of treatment. And any patient who has an end-stage liver disease and having a child pug status C and performance status of 3 or 4, their median survival is 3 months, and we only advise best supportive treatment. And with the updated BCLC, we have the concept of stage migration. And if you are able to downstage the treatment with advanced therapies, we can reassess the patient and offer them potentially curative liver transplant, or we can do curative options can be offered to these patients. And a multidisciplinary team is very essential for successful management of HCC. Thank you.
Thank you, Jatin, for that nice overview of the clinical presentation and how we approach this hepatocellular carcinoma, how we diagnose it, and how we proceed with the treatment. Nice overview of the BCLC algorithm, the changes they have made in the recent BCLC 22 staging and the
Sure.
treatment advice. So I thank you for a nice and lucid talk. Then we'll move on to the next talk by Dr. Sumana Ramchandra. She is a senior consultant liver transplant surgeon in AIG Hospital. She will be going to talk about the surgical management of SCC. She will take us through the nuances, what are the recent developments in the surgical arena. So with this, I will like to invite Dr. Sumana for her talk. Over to you, Dr. Sumana. Ma'am, are you there? Dr. Sumana?
Can you hear me?
Yeah, ma'am.
Yeah. 1 second. I think there's some. Okay. So I need to share my slides. I was just trying to see how I have to do all this.
Hello, ma'am.
Yeah.
Yeah, do you want to see the share button on your screen?
No, actually I was in the settings only. I've made it actually to share.
Ma'am, are you on the Zoom?
I'm on Zoom only. Okay, share. Can you see?
Yeah. Yes, ma'am. Your screen is visible.
Yeah.
Yeah. Okay. So can you make it this full screen?
Yeah, I do that. Okay. Can you see it right now? And can you hear?
Yes, ma'am.
Okay. So thank you all.
Sorry,
And
sorry to interpret, ma'am. Sorry to interpret. This is not on full screen. Do you see the play button? Yeah. Just click. Okay, ma'am.
Okay, I'll take you through the surgical management for HCC. I'll also talk about both surgical resection and transplant. So what are the advances that has been happening with resection, and how the resection, which was not initially so much actually talked about, and now in the last 10 years people are talking about resection before going into transplant, and then the indications of transplant and what are the advances, and about downstaging of the disease before we do the transplant. So to begin with, I think I will not go delve too much into it. The global overview has already been talked about. But in Indian setting, we see that it's a growing concern, and the main problem that we see in India is that we see these patients very late. Most of the times that when these people come to us, they're either advanced liver cirrhosis, or they have an advanced disease with portal vein thrombosis, or sometimes even metastatic diseases. So these are the patients that we are dealing with, and we all know that the treatment for HCC have evolved a great deal over the last 4 decades, and surgical treatment remains the mainstay of curative treatment options. In the realm of surgical treatment for HCC, they include surgical resection and liver transplantation. So this just now, I think Dr. Jatin has actually told us about the newer BCLC staging and the stage migration, and they've also talked about the successful downstaging and curative treatments thereafter. I'll come back to this later. Uh, so if you look at if you really look at this also very early disease, they said that if there is no significant portal hypertension, you go for resection, and that was curative. And the indication separately will come back to the indications for liver transplant. So I'll just briefly talk about this liver resection versus liver transplant multicentric study, meta-analysis for patients who had HCC within Milan criteria. So here they took 35 studies, and out of which there were like 18,421 HCC patients within Milan criteria. And they saw that the liver resection had a poorer overall survival compared to those patients who underwent liver transplant with similar findings. Patients who underwent liver resections had almost threefold risk of HCC recurrence compared to patients with LT who underwent liver transplant. And even they said that the liver transplant remains the ideal treatment option for HCC by removing both the tumor and the surrounding diseased liver, thus addressing the field change effect and lowering the risk of recurrence. However, among the patients with uninodular lesions within the Milan criteria, there was no significant difference in the overall survival between the liver resection patients and the liver transplant patients, although the risk of recurrence remained around threefold in patients who underwent liver resections. For such patients, liver transplant is the ideal and long-term curative treatment, was the conclusion. So in summary, they said mortality was nearly 50% higher in patients with HCC treated with liver resection versus LT. But if you look at this, when they looked at patients who underwent the liver resections after 2010, they found that the overall survival in these patients were not better than LT, but the overall survival in these patients improved compared to patients who had liver resections compared to the studies that were published before 2010. So the reason probably because the reason for this probably was because of better surveillance in these patients. So they said that a greater effort should be made to improve the adherence of surveillance for HCC recurrence, especially after liver resection. So this study, this meta-analysis told us that the patients there is a difference between both the overall survival in resection and compared to liver transplant. But in uninodular diseases, the difference is not too much. Okay, so when we look at a patient and see, okay, if it is within Milan criteria, what would we think of? Like, how do we select these patients for resection or liver transplant? So the key considerations in deciding between liver resection or transplant is that you have to look at you have a patient, you have to look at multiple things. You have to see the liver function, you have to see which category they belong to based on the CTP scoring. Then you have to look at their MEL scoring. Then you see the long-term outcomes in these patients based on the fact that there is cirrhosis and is there recurrence in the remnant liver. Especially the hepatitis B and hepatitis C patients, and now even the NFLD patients, the risk of recurrence in the remnant liver seem to be much higher. And obviously, the availability of organ for these for transplant. Whether you look at you see the Western data where you look at the DDLTs, and if you come to the eastern part of the world, then you see whether the patient has an availability of the living donor. So this is how you look at a patient and then decide, okay, whether should we go for a resection or transplant. So the other things that we look at is mainly in the screening process, apart from the liver function and the tumor related AFP and PIVCA, you do a triphasic CT, which also helps us in actually planning of the surgery. Triphasic CT is much better, but probably because the surgeons are used to it. But the triphasic MRI is also equally good. So what is the most important thing which will tell us as surgeons or any physician whether we can go for resection? One is you look at the CTP score. It's always better that if you're going to do a segmental resection of more than 2 segments, then it is always better that these patients are CTP-A. In CTP-B, maybe we can look at individual small single segment resections without much complications. So you look at their MEL score. And apart from this too, the things that we need to see is that how bad is the thrombocytopenia. So if the platelet count is less than 1 lakh, then you always think whether these patients do well after resection. Then is there ascites? Is it like significant ascites? Are we giving medications to control ascites? If you see their upper GI endoscopy and see what kind of varices they have. So these are all the things which tell us how bad the portal hypertension is. So the best way to actually to quantify the portal hypertension is the hepatic venous portal venous gradient, which is HVPG, which is recommended. And they say that if the HVPG is less than 10 mm, then you go for resection. If it is more, people still have done it, and some publications are there, but the results are not as good. So HVPG is an interventional procedure. So some people may not look at this, and they probably look at other factors like the thrombocytopenia and upper GI endoscopy. But I would suggest that if you're planning a resection in patients who have with a background of cirrhosis, it is always better that we do an HVPG and make the decision. So there are three main areas for consideration in liver resection for HCC. One is obviously every one of us know here that the purpose of the whole thing is to remove the tumor, and the oncological appropriateness is most important here. So resection of the liver tumor to achieve survival benefit. There is no point in not doing an R0 resection, especially in a cirrhotic patient, and trying to give them the option of cure. If you're not able to give the appropriateness of oncological resection. So then the host condition. So apart from the general health of the patient and fitness for surgery, you also look at the remnant, like say the remnant liver, like say how the quality of the liver, like say if they have a background, you have to look at hepatitis B. Hepatitis B is quite a the recurrence of the tumor in hepatitis B patients in the remnant liver is much higher, and we know the reason that the genome itself is embedded embedded into the hepatocyte. So that is the reason why when we have hepatitis B patients after resection, the recurrence rates could be much higher when compared to the other underlying diseases. So technical resectability, which is important for a surgeon who is looking at it. Say you look at the tumor, you see what are the size. Say, like I said in the study, in the meta-analysis, they said that if it is uninodular lesion, the recurrence rates and overall survival is much better. But you can still say if they are small tumors, especially within Milan is what we are looking at. If the tumor is like in the same segment, but there are multiple, or you're trying to take away only two segments, then you'll have to look at whether if you're trying to take away two segments, are we taking out the whole tumor here? And then we have to look at the vascular inflow and outflow and the biliary drainage. And most important, like I said, apart from the disease per se, the most important thing that we need to consider in patients who are undergoing liver resection is the future liver remnant volume and the quantity and the quality. So again, coming back, so we know that these patients have background cirrhosis. Whether the portal vein is involved or not involved. Say sometimes this is a little going beyond the what is the guidelines. Say sometimes there is a portal vein thrombosis. If it is a bland thrombosis and it is just in the second order, third order, it's okay. But if there is a tumor thrombus involved and we are doing a major resection, then we know that the risk involved is much higher and mortality rates are also higher in these patients. So you have to look at, like already I said, the remnant liver function and the percentage of liver that you're going to leave behind is a very important thing in patients when you look at the resection as the possibility of cure. So like discussed, I said that portal hypertension is not a contraindication, but if you compare patients with and without significant portal hypertension, there is a difference in the significant difference in the patients who have had portal hypertension and patients who have not had significant portal hypertension. So like I said, sometimes these patients who have HCC, maybe they are in single segment, but there is a portal vein tumor thrombosis. And in these patients, we know that these patients actually have a bad disease. Like say, people who have developed portal vein thrombosis, could be one reason could be that the tumor is very much nearer to one of the pedicles, or the disease is so aggressive that there is already a vascular involvement. So it could be, or it could be a pure poorly differentiated tumor. So in these patients, though, many people don't try to do, especially in a background of cirrhosis. If there is no background of cirrhosis, obviously liver resection is indicated if in these patients, even if there is portal vein tumor thrombosis. But there are studies where they have seen that in VP1 and 2, that 3 is not appropriate. They are able to enjoy survival benefit ranging from 54 to 25% at 1 year after surgical resection. Even with VP1 and 2, this is one of the publications, and this is compared to the other modalities where other modalities like TARE or TACE, they have better survival at 1 year with VP1 and 2 tumors, tumor thrombosis. So they have also, I mean, in the patients, the resection is possible in patients with hepatic venous tumor thrombosis. Like I said, the surgical, the outcomes or the mortality and morbidity in these patients are much higher. But there have been studies where they have done this and proven that it is better than other modalities if we can go ahead and do a complete R0 resection. Like I said, giant HCC in a background cirrhosis, it is controversial because the morbidity is up to 50% and mortality is up to 8%. Like I said, if in a large HCC, large giant HCC, but with a background of tumor, like say if there is an exophytic component, or if it is just involving only 2 segments, or if it is involving a left lateral segment, you can still go ahead and do a resection in these patients, because majority of the remnant, remnant volume is still remaining in these patients, and the requirement of the in a patient with HCC, I mean, and background cirrhosis, the remnant volume should at least be 40 to 50%, if the HVPG is less than 10%. So this is another diagram I'm just trying to, which is showing that this is a study from France, where the liver resection for HCC in patients with clinically significant portal hypertension. So like I said, the mortality is much higher compared to patients who have not had significant portal hypertension, but it did give them better survival compared to the other modalities. So final considerations for resection. So I'll be moving on to liver transplant here. So before that, I would say that resection is indicated. This is the guidelines indicated in uninodular lesions with Child's A, bar B with an HVPG of 10 or less than 10, and with a good remnant volume and good performance status. And the liver resections can also be attempted for advanced HCC with vascular invasion after accepting the morbidity and mortality, if it is going to offer better survival than other modalities, and if the other modalities are not feasible. So moving on to liver transplant, we all know that the liver transplant is a best form of treatment, curative form of treatment for any patient with HCC. And that the reason behind it is that the reason is that you are curing the disease, and you're also removing you're curing the HCC, plus you're removing the underlying diseases, which gives a better survival in these patients, and it has become the standard of care. So the Milan's criteria provided us the opportunity for HCC patients to undergo liver transplant with favorable outcomes. And when they saw that it became an international gold standard. So in the 80s, transplant, actually the history is like in 80s they did transplant for HCC. There was no criteria developed in that time. And Mazzaferro reported the Milan criteria based on a prospective study in 1996, and he came up with the Milan criteria, where a single tumor of less than 5 centimeters in diameter or up to 3 tumors of less than 3 centimeters in diameter with no extrahepatic involvement and no evidence of gross vascular invasion. And the survival rate at that point, at 4-year survival rate, was 75%. So this again, like I said, it's a single tumor, and or if there are more up to 3 tumors, none more than 3 centimeters. The 5-year survival with transplantation was approximately 70%. So we all know this, the metro ticket, the farther you go, the farther you the more you pay for it. So this is Milan criteria, and then came up the extended criteria, which is still accepted as a standard of care internationally. And the UCSF criteria said that it said that the tumor size should be equal or less than 6.5 centimeters, and 2 to not more than 3 lesions, none exceeding 4.5 centimeters, with total tumor diameter less than 8 centimeters, and no vascular or invasion or extrahepatic disease. So after that, there have been multiple criterias which have for HCC treatment, liver transplant for HCC. You have the Pittsburgh criteria, then Hangzhou criteria, up to 7 criteria, and the Toronto criteria. I'm not going through the detail of all these criteria. So, but eventually from just Milan, it went up to UCSF, and many people have their own criterias. And they have shown that the 4-year overall survival rate in these patients are approximately or equal to 70 or more than 5-year overall survival. So these are all based, these are the criteria which are based mainly on morphology and the number. But eventually the criteria started using surrogate markers for biological behavior of HCC, and this inclusion, especially these are patients who especially these are papers which came from eastern part of the country. And I will not go into again detail of all this. When I come to advanced HCC, I'll give some more details. So now, apart from the Western data and the international standards of the gold standards of indication for liver transplant, and mainly these are centers which have a DDLT program. So coming to the centers which are doing a living donor liver transplant, that is mostly the eastern part of the world, they started using transplants for patients which have with a much more advanced disease. And because we especially, like I said, especially in India, we see tumors from just single lesion to multiple lesions. Like it can be multifocal, which can be large with the vascular involvement, or it can be whatever we see is never, like, say, rarely we see patients who come within Milan, or mostly within Milan. We see a lot of patients within UCSF, which we deal day to day. And like I said, from just morphological criteria, there has been inclusion of biological criteria in deciding the selection criteria for transplant, and that has been adopted by Japanese Liver Society, UNOS, ASL, and ASLD. So the biological criteria which have been included are the AFP, PIVCA, and PET, and after the response to local regional therapy, that is downstaging, and you wait for these patients and see if there is no 3-month progression. You also use NLR and histology and biomarkers. There are novel biomarkers like liquid biopsy and molecular criteria, which I'm not going to deal with. So downstaging, conventionally, PVTT used to be a contraindication for liver transplant. With downstaging, even this group can have long-term survival with resection or LT. The concept of double equipoise, that is the maximum recipient benefit with minimal donor risk, I'm only talking about the living donor liver transplantations here, should be the motto. And downstaging is recommended in LDLT even with adverse biological factors. Minimal recipient survival is contentious, and transplant benefit is a better metric. So there are multiple, like I said, there are multiple studies which have come from mostly eastern part of the world, and there have been case reports, and There's a living donor transplant for HCC. So these are all these are all the studies that we have come, and so one of it is from Seoul, Asan Medical Center, and then they said they saw the 17 they considered 17 patients with HCC with PVTT who underwent downstaging with TACE and radiotherapy followed by LDLT, and they showed that the 3-year disease-free survival and overall survival were 57.8% and 60.5% respectively. We also have a similar study from our own country, from Medanta, they looked at 25 patients of HCC with PVTT followed by LDLT post downstaging, and they also gave similar results. 1-year survival was around 75, and at 3 years 53, and at 5 years also around 52 to 53%. So this is selection criteria based on transplant benefit. So you have like this was actually published in this is from the consensus, ILTS consensus. This I think they compared with the best alternative therapies. The transplant benefit is offered by LT in comparison with the best alternative therapy, and they looked at the TACE and LT after downstaging. They also looked at LT resection and TACE, LT followed by downstaging, and then the resection and TACE, and they found that there is an advantage of transplant, and that the transplant benefit is there in these patients. So, like I think Dr. Jatin has already told that, stage migration where there is this new BCLC staging also recommends. And if you look at that, once you have downstaged it and transplanted, they have better survival than just downstaging them and leaving them alone. So going beyond the routine and like pushing the limits, you still give them an advantage, and that is the transplant benefit. So especially for patients who have advanced disease, and you look at their survival, their age, and if you consider their performance status, you can still select these patients and offer them downstaging followed by liver transplant. So this is again this is just the data showing that the transplant benefit. Without transplant, these patients' survival within Midlands, if you see the survival 3 to 5 year survival post transplant is 85 to 80%, and if you don't transplant them, it's about 25% and 0% at the end of 5 years. If you take large tumors without the PVTT, 3 to 5 year post transplant survival is 75 and 65. With no transplant, it is just 10 and 0. So there is, even with the advanced disease like HCC with PVTT, you downstage them with TARE and SBRT, and now we are talking about immunotherapy plus LDLT. You still, though there is not much data downstaging them to by immunotherapy and then LDLT, there are 3 to 5 year survival is 65 to 55%, and without transplant it is 0. So this is a recently published case report, successful liver transplant after achieving complete remission with in advanced HCC with atezolizumab plus bevacizumab combination therapy, and this they published, and I got this. I think it's a recently published article. Even we also have data. We have had some 7 patients who underwent who had advanced disease. We downstage them with some of them with SBRT and TACE and immunotherapy plus SBRT. And we have transplanted these 6-7 patients, and I think we have not yet published, but probably sent for publication. So out of 7 patients, we lost only 1 patient due to post-op sepsis. Otherwise, all of them are doing well. This has been done in the last last 1 year, end of 2023 to 24. So eventually, I think the only thing that all of us should understand when we are giving surgical treatments is that it is a multidisciplinary approach, and we have to all sit together and decide what is best for each individual, rather than going by just what has been practiced so far. We have to select these patients who have advanced disease by looking at multiple things and discussing whether we are really giving them good oncological or a transplant benefit, and at least a survival rate which is far better than just downstaging them and just leaving them with the downstaged disease. Thank you. Any questions?
Thank you, ma'am, for that very good presentation about you took us through the journey of liver resection, transplant, how the criteria have been changed now, and we are considering a lot of advanced tumors for transplantation by downstaging them. So that's a very nice overview we have heard from you. Thank you once again for your presentation. Now
Thank you.
we move on to the next topic. For this, I think Dr. Dharmesh is not here. So I will be presenting the next talk about the management of intermediate stage HCC. So the many new data has come up now. The Emerald trial, I will be discussing about that. Let me share my slides here. I think my slides are visible. Are my slides visible?
Yes, yes, it's visible.
Okay. So let's start with the emerging treatment options in the management of intermediate stage HCC. So this is about the epidemiology. We already talked about it, that liver cancer is the 10th most common cancer type and 8th most common cancer related deaths is attributed to HCC. Is the second most common cancer, the cause for death in men, and we see around 30,000 odd cases every year. It's the 2020 statistics, and it's a highly it's associated with very high mortality. So many of the patients in our country, they present in advanced stage. The liver function is already very poor, and these patients do not tolerate all the treatment which we give, and eventually it's associated with very high mortality. BCLC staging, we have gone through this, that as the stage advances, we know that the survival decreases. Very early stage, we sometimes they get picked up during the screening. Otherwise, most of the patients come in the advanced stage. Even in our center, when they come in the advanced stage, and most of them are having a poor prognosis because of the poor liver function associated with it. So we are dealing with two diseases in this tumor. We know that it's a liver disease, as it already has the cirrhosis. They have the portal hypertension. If they don't tolerate the treatment, even if we give the treatment, many of the patients develop liver failure. So the decompensation occurs with the treatment. So basically, the tumor involves a multi-modality management. So we need hepatologists, we need surgeons, we need interventional radiologists, everyone. And as a whole, we plan a treatment which is suitable for that patient. Again, nearly 30% of patients of HCC present in the intermediate stage. So the disease is still confined to the liver. It's not in the resectable criteria. It's too advanced for resection or transplantation. Also, maybe we consider loco-regional therapy in these patients, maybe TACE or TARE. Then if we downstage now, we have got many curative options. So if we downstage, give some immunotherapy or combined with the loco-regional therapy, it's an excellent response, and the AFP is decreasing and the tumors are reducing, then we can consider for curative options also. So that is how the treatment has changed in the HCC nowadays. And TACE, as we know that it is basically we are giving the chemotherapy through the intraarterial route into the tumor. So we are using doxorubicin, and some of the newer TACE modalities or DEB TACE has come up now, drug-eluting beads. So the chemotherapy is directly given into the tumor. So many meta-analysis have been done, and the what are the outcomes which we achieve with TACE is around the median OS is around 19.4 months. So, and we can expect a 5 year survival of around 32% according to the meta-analysis here, and how we can improve this the outcomes in this intermediate stage HCC, which are not resectable, and even after downstaging they are not eligible for any curative treatment. And then what are the options we have got? So to improve the outcomes, so many studies we have got multiple published studies about combining TKI with the local regional therapies, immunotherapy along with TACE or TARE, and also many of these studies are still going on, but there's no conclusive evidence till date, except we are going to discuss about the Emerald trial, which has shown to us that the outcomes improve when we combine the treatment modalities. So if systemic therapy is combined with the loco-regional therapy, it is going to improve the outcomes in this intermediate stage HCC. So he's already gone through this. So basically what happens in the tumor evolution. So basically this liver disease acts as a breeding ground for the development of the tumor, and the tumors, we know that we are dealing with two diseases, this cirrhosis of liver and the tumor itself. The taste is considered for the well preserved livers. So the tumor is actually in the still not advanced. It's multiple nodules which cannot be offered any curative treatment. We offer TACE there, and now we are combining the modalities like TACE plus immunotherapy and TACE with TKIs to get better outcomes. So what does this immunotherapy do in the when it is combined with TACE? It actually reduces the additional TACE sessions. So TACE is not the only modality which we can offer in the intermediate HCC. It can be combined with other systemic therapies. So it reduces the sessions of TACE. It preserves the hepatic reserves. The liver function is preserved by giving some form of systemic therapy, because as we give multiple sessions of TACE, so the even the normal liver gets damaged, and in a patient who has already a compromised liver, this TACE will lead to further liver damage. So this is kind of preserved by giving the systemic therapy, and when we take care of the liver function and also the tumor, and definitely it's going to improve the outcomes and survival. We know that HCC, the tumor microenvironment is very highly immunogenic. So a lot of immune cells are seen in the tumor microenvironment, and it's a very vascularized tumor. So what we do, the idea behind combining this TACE with checkpoint inhibitors and anti-VEGF, all the preclinical studies have shown that these act synergistically, and once we block the blood supply to the tumor using the anti-VEGF by leading to the normal vascularization, this kind of makes more the tumor very immune. The lot of immune cells infiltrate the tumor. Once they are activated with immunotherapy, then we see the tumor cell kill. So this is the basis of combining the multi-modality treatments like IOs with TACE, anti-VEGF with TACE, and IO with anti-VEGF. This was one trial which has seen about combining TACE with a TKI tactics trial. It was in the unresectable HCC. they have seen that when we give TACE along with any TKI, nearly 60 odd patients in this study, it leads to a PFS of around 24 months. So with only TACE, we can expect PFS around 18 months. When we combine with some TKI, we are seeing a PFS of around 24 months. And the overall survival is very good here. The 6 months OS rate is 98% when we combine a loco-regional therapy with the TKI, and the 1 year survival is around 90%. So this is when we combine the different modalities, the loco-regional therapy and systemic therapy is definitely going to lead to better outcomes. Again, this immunotase, this was one study when they have seen, it's a phase 2 study when combining immunotherapy along with TACE. So they have combined TACE with nivolumab in intermediate stage. This study showed a good responses. The overall response rate was around 70% and nearly 8% patients had CR. So that is how when we combine the systemic and the loco-regional therapy, it's definitely going to improve the responses and also the survival. So Emerald trial, this study was reported in this ASCO, and this year, this was actually a good study where it's a randomized study, phase 3, which involved the intermediate stage HCC, which were not eligible for any curative treatment, any ablation, surgical resection, or not for transplant. There was no extrahepatic disease. They included all the well preserved liver functions, and the performance status was good. They did not include the VP3 and VP4. So the major involvement of the portal vein and the neighboring vasculature, these patients were excluded from this trial, and no prior therapy was allowed. And the stratification was based on the TACE modality, whether it was depth TACE or conventional TACE, according to the geographical region, and also based on the portal invasion, whether it was VP1 or VP2 versus none. It's a 3-arm study. Basically, durvalumab was combined with TACE in the arm A, followed by only durvalumab maintenance. The durvalumab plus bevacizumab maintenance. In the arm B, it was durva with TACE followed by durva bevacizumab. Here it was placebo for bevacizumab. It was only maintenance durvalumab. And in the second arm, it was durva bev maintenance. They did not give bev during the TACE period. And in the arm C, it was placebo plus placebo for durvalumab plus TACE was then followed by maintenance only with placebo for both durva and bevacizumab. The primary endpoint was progression-free survival of arm B versus arm C. So basically, the durva TACE versus placebo was the primary endpoint. Secondary endpoints was PFS for arm A versus arm C. So they wanted to look at durva bev, durva with all of versus arm C, that is only placebo. The secondary endpoints are again were response rates and also the quality of life measures. So the arm B versus the only placebo TACE, there's a significant improvement in the progression-free survival. We can see it's almost doubled here. Depth D plus B durva bev TACE versus placebo TACE, a 7 months improvement in the progression-free survival, has significant hazard ratio 0.7 and also significant p-value. You can see the curves have started separating after, almost after 4 months. So after this TACE was given with the durvalumab, after the 4 months, the curves have started separating here. The delta the 12 months was around 16%, and at 18 months it was around 15%. So the curves are well separated, the response is maintained, the survival benefit is maintained till the tail of the curves here. All subgroups benefited with this regimen durva bev with TACE. the PFS benefit was consistently seen across all the subgroups here, despite the geographical region. Portal 1 invasion, so a lesser number of patients, so it's crossing unity here, so might not be significant. Any patients beyond even 7 criteria, what we take for the TASE, even those patients benefited with the addition of Durvabev to the loco-regional therapy. So what with the again, there's a Durva alone arm, when Durva combined with TASE versus TASE, so arm A versus arm C, it was actually, the study was designed to show the non-inferiority of Durva TASE versus TASE, and it actually met the endpoint. So even the hazard ratio is crossing unity, but since it is a non-inferiority study, the upper confidence interval is not crossing the expected confidence interval, and though the curves are overlapping, there is some significant improvement we can see, the non-inferiority study, but p-value was not significant. Numerically there was improvement, but the p-value was not significant, and the non-inferiority was not proven here. So the objective response rates, we can see it's quite 40%, 43% with Durva-Bev test as compared to Durva test 41, and with the placebo test is around 29%. So some CRs was also seen with Durva test around 3%, and also with the Durva test alone. So well tolerated regimen when we combine with the taste, this not much adverse events in this study. The grade 3 events were around 27% in the Durva test. That's quite acceptable. Durva Bev test was 45%. If you don't see some adverse events, it's like most of the patients tolerated well, and the placebo test it was 23%. So the adverse events leading to discontinuation was around 24% the Durva-Bev test as compared to 12% the Durva test, and placebo test was 7%. So what we have to conclude with this study is that we know that intermediate HCC has a very quite heterogeneous presentation. So we have it's not one disease we are dealing with, multiple case scenarios, multiple types of presentation. Each patient is different. We have to look at the liver disease. We also need to plan what loco-regional therapy to be given. So if there is some portal vein invasion, then TASE cannot be considered. Then we have to opt for TASE. But BCLCC was also very heterogeneous here, and we have seen the rationale of combining TASE with the immune checkpoint inhibitors in this study. So it works well. So when loco-regional therapy is combined with the systemic therapy, it leads to the better outcomes. We have seen a median PFS of around 15 months, nearly doubling of the PFS as compared to placebo test. So it's not yet mature to show the overall survival, but it's an early signal that systemic therapy, especially the immunotherapy, when combined with the loco-regional therapy, it leads to better outcomes, and that's what this study has shown us. And with this, I would like to conclude my talk, and thank you all for your patient hearing, and we move on to our next session, I think. If
2 minutes and ma'am is joined.
so Dr. Monica is available. Yeah. Hi, Vishal. Can we move on to the next session?
Uh, 2 minutes, sir. Ma'am is joining.
Okay. So let me introduce Dr. Monica is a consultant medical oncologist at the KIMS Hospital, and she will be talking about the newest advances in the advanced SCC, that is the Himalaya trial. Basically going to discuss about the stride regimen, how it has been transforming the treatment of this advanced SCC. So over to you, Dr. Monica.
Sir, ma'am is here. Monica, ma'am.
Yeah, I'm there. Can I start sharing my screen?
Yes, ma'am.
Can you see the slides?
Yes, ma'am. Please make it full screen.
Yeah. Very good evening, everyone. Today I'll discuss the Himalaya trial data in maybe about the next 20 to 25 minutes, and then any questions we can take after that. So Himalaya was the phase 3 randomized open label multicenter study of tremelimumab and durvalumab as first-line therapy in patients with unresectable hepatocellular carcinoma. If you look at the cancer immunity cycle, there is a presentation of the cancer antigens to the immune cells by dendritic cells and other antigen presenting cells. And when these cancer antigens are presented to the T cells by the dendritic cells and antigen presenting cells, there is something called as the T cell priming and activation that happens. Usually that happens in the lymph nodes. And these activated T cells, which have been primed and activated with the ability to kill the cancer cells. That's predominantly the cytotoxic T lymphocytes. They enter the bloodstream. There is trafficking of the T cells to the tumors, and there is infiltration of the tumors by the T cells. So once the tumor is infiltrated by the T cells, and there is recognition of the cancer cells because they've already been primed, because the cancer antigens have been presented by the antigen presenting cells to the T cells. The T cells are primed to recognize the cancer cells. And then that causes, then they get activated, and there is killing of cancer cells by these cytotoxic T lymphocytes. When the cancer cells get killed, there is release of more cancer cell antigens, and then there is in turn more antigen presentation and more activation of T cells. So this is how the cancer immunity cycle goes on. Of course, this is not as easy as it looks, as it happens in our body. It's not as easy as said. There are so many multiple factors which actually influence this process and which don't allow this kind of a T cell activation to happen. There are various checkpoints in place, and cancer has its own mechanisms of immune evasion. We all know that very well. Coming to durvalumab, this is an anti-PD-L1 monoclonal antibody. That is the ligand. It's basically a monoclonal antibody directed against the ligand, the PD-L1, which specifically binds to PD-L1, thereby reversing T cell exhaustion. It is highly selective. It has high affinity. It's a high affinity human IgG1 monoclonal antibody. By binding to PD-L1, it blocks the PD-L1 binding to PD-1, because this interaction at this checkpoint leads to T cell exhaustion. So durvalumab, by preventing the interaction between PD-L1 and PD-1, is able to reverse the T cell exhaustion and allowing the T cells to recognize and kill tumor cells. The other important features of durvalumab are that there is an engineered triple mutation in the Fc domain of this monoclonal antibody in order to remove antibody-dependent cell-mediated cytotoxicity and complement-dependent cytotoxicity. There is a low incidence of anti-drug antibodies because of this. So the incidence of anti-drug antibodies forming and thereby affecting the efficacy of the drug is only 2%. So these are the attributes of durvalumab. So this is durvalumab that binds to PD-L1, and this prevents the interaction between PD-L1 and PD-1. PD-1 is on the anti-tumor cytotoxic T lymphocytes, the CD8 positive T cells. PD-L1 is present on the tumor. This interaction is prevented by durvalumab, and that enhances the anti-tumor efficacy. Tremelimumab, if you see, this is a human IgG2 monoclonal antibody that is directed against CTLA4. So it's an anti-CTLA4 antibody similar to ipilimumab. CTLA4 blockade with tremelimumab induces T cell proliferation within the lymph node, restoring the anti-tumor effector and memory T cell responses. So it basically blocks the CTLA4 interaction with B7.1, B7.2, allowing T cell stimulation by the antigen presenting cell. So this interaction occurs at a much earlier phase. In this tumor immunity cycle, if you see, this is the place, that is the phase of antigen presentation where CTLA4 actually comes into play. So tremelimumab causes T cell stimulation by the antigen presenting cells by blocking this in the lymph node. This happens in the lymph node, thereby helping to restore the immune response to the tumor cells. Tremelimumab treatment enhances effector T cell priming and restores effector and memory CD4 positive, CD8 positive T cell populations in response to polyclonal activation and tumor antigens. So this is tremelimumab, and this is the CTLA4, which is present on the CD8 positive T lymphocytes. Tremelimumab goes, so normally this has to interact with the B7.1, B7.2 receptors, which are present on the antigen presenting cells. And this interaction prevents effective activation of the CD8 positive T lymphocytes. So tremelimumab, by binding to CTLA4 and preventing this interaction, helps in better activation of the T cells, the cytotoxic T cells, and therefore it helps in restoring the immune responses, and that increases the anti-tumor activity. And it also binds to the CTLA4, which is present on the Tregs, which are immunosuppressive. They reduce the anti-tumor immunity. So by binding to the CTLA4 present on the Tregs, it prevents immunosuppression, which is caused naturally by the T regulatory cell. So that's how it acts at two places. So that is about tremelimumab and the CTLA4 B7.1, B7.2 interaction. Combining these two immunotherapies, therefore, may further improve the clinical outcome because we are removing the checkpoint at the level of antigen presentation as well as at the level of the final cytotoxic killing. Tremelimumab blocks the suppressive T cell signaling in the lymph node. Durvalumab inhibits the suppressive PD-1, PD-L1 interaction in the tumor microenvironment. So the CTLA4 antagonists act at the lymph node, and the PD-1, PD-L1 interaction happens in the tumor microenvironment. So durvalumab acts within the tumor microenvironment. So both of them together, they complement each other's immunostimulatory, anti-tumor immunostimulatory effect, and they drive anti-tumor activity by distinct cellular mechanisms. So the rationale for immunotherapy combinations is anti-CTLA4 and anti-PD-1, PD-L1 antibodies together will cause enhanced synergistic anti-tumor activity. The revisiting anti-CTLA4, anti-PD-L1 combination, high dose T combined with, so if you look at the tremelimumab, which blocks the suppressive T cell signaling in the lymph node, and durvalumab inhibits the PD-1, PD-L1 suppression. So durvalumab continues to maintain immune activity through inhibition of interactions between PD-1 induced on the activated T cells and interferon gamma-driven PD-L1 expression in the tumor microenvironment. In solid tumors, immune checkpoint inhibitor regimens incorporating higher doses of anti-CTLA4 combined with anti-PD-1 or PD-L1 are often associated with improved overall survival. We have all learned that from many other malignancies as well, including the first malignancy from which we learned this combining CTLA4 and anti-CTLA4 and anti-PD-1, PD-L1 antibodies was melanoma. And that led to improved overall survival compared to those with lower doses of anti-CTLA4. But of course, there is an increased toxicity, definitely. In melanoma, the initial dose of ipilimumab, nivolumab caused a proliferative burst of peripheral T cells, which is not repeated at subsequent doses. If you see, there is a sudden proliferative burst of the T cells, and then that is not maintained in the further dosings also. So then the question arises, could a single priming dose of tremelimumab with durvalumab, could it improve immune-mediated clinical activity in HCC patients while minimizing the toxicity? So just a single priming dose. Now, most of the protocols, that's what we are doing, that we're just giving a single dose of ipilimumab in the beginning with this first cycle, and then we're just continuing the anti-PD-1 or PD-L1 antibody. So whether we can do that with HCC also, that is the question. Himalaya is a global trial. It enrolled patients in about 16 countries. Overall, 190 trial sites are included in Himalaya with enrollment and randomization of about 1,324 patients. So there is a good representation from the Caucasian population as well as from the Asian population. There is a separate Himalaya China trial, which is we are awaiting for the results to be out. Now, look at the Himalaya study design. If you look at it, Himalaya was an open label, multi-center global phase 3 trial. The study population consisted of patients aged 18 years or older with unresectable HCC, BCLC stage B, who were not eligible for any loco-regional therapy, and stage C patients were included. They should not have received any prior systemic therapy, and they should have been of ECOG performance status 0 to 1. Child-Pugh A patients only were included in this trial. There should not be any thrombosis of the main portal vein. That is important. It was not necessary to do an upper GI endoscopy at baseline because this trial did not use VEGF inhibitor, unlike the IMPAR trial where atezolizumab bevacizumab combination was tested where it was mandatory to do upper GI endoscopy before trial enrollment, and any significant varices had to be dealt with before the patient went on to the combination of atezo-bev. Now, bevacizumab, because we know that it increases the risk of bleeding complications, especially when large varices are present, so they had to be tackled before the patient went on to the trial or onto that particular regimen. But here that was not required because this trial did not use VEGF inhibitors. So there were about 1,324 patients who were randomized. Patients were stratified according to macrovascular invasion, present or absent, etiology of liver disease, viral etiology versus others, and performance status ECOG 0 versus 1. It had 4 arms. One arm, the first arm had tremelimumab 300 milligrams with durvalumab. Single dose of tremelimumab 300 mg was given, and durvalumab was given 1500 mg once in every 4 weeks. The other arm had durvalumab monotherapy, which gave 1500 milligrams once in 4 weeks. The other arm had sorafenib at its standard dosing, that is 400 mg twice daily. And the other arm had tremelimumab at a much lower dose, 75 milligrams given once in every 4 weeks for up to 4 doses, and durvalumab 1500 milligrams once in every 4 weeks, and that was continued. So treatment was basically continued till disease progression. Patients with progressive disease who, in the investigator's opinion, continued to benefit from the treatment and met the criteria for treatment in the setting of progressive disease, they could still be continued on this treatment regimen. The 75 mg tremelimumab arm was closed following a pre-planned analysis of a phase 2 study. So this arm got closed. So we are mainly concerned with these 3 arms. Patients randomized to this arm, they were about 153 patients only here, whereas the other 3 arms had almost close to 400 patients each. So these 153 patients, they could continue treatment following arm closure also. Results from this arm are, however, not reported otherwise. Now, the outcomes that were looked at, mainly the primary endpoint was overall survival in the 300 mg tremelimumab arm, 300 mg tremelimumab with durvalumab as compared to sorafenib. That was the primary objective. Key secondary objectives included overall survival for durvalumab as a standalone agent versus sorafenib, and additional secondary objectives included PFS, overall response rates, duration of response, and also safety was an important parameter that was assessed. So there was a multiple testing procedure. So there was a layered analysis which was done. Overall survival superiority for 300 mg tremelimumab with durvalumab. So T300 plus D, that is what we'll call it as, versus sorafenib had to be demonstrated. And then OS non-inferiority for durva versus sorafenib, the non-inferiority margin being 1.08. And then OS superiority for durva as compared to sorafenib. So this was how in a stepwise manner, the parameters were assessed. So that's a multiple testing procedure. The treatment regimens for Himalaya arms A, B, and C, 4 weekly cycles. Durvalumab 1500 mg was always given 4 weekly. And durva tremelimumab, this was the arm that used only 75 milligram of tremelimumab. So 4 doses were given. And durvalumab was the same, 1500 mg once in 4 weeks. So after 12 weeks, the first assessment was done. And then durvalumab with a higher dose of tremelimumab, but a single priming dose, that is 300 mg single dose, was given in the beginning along with the first dose of durvalumab. And following that, there was no tremelimumab at all, and only durvalumab 1500 mg once in every 4 weeks was continued. Sorafenib was a continued dosing. Now, the single priming dose was because of the studies that showed that surge of activated T cells, even after subsequent repetitive doses of CTLA4, anti-CTLA4 antibody, that surge that was there with the initial dose, that surge did not happen again with subsequent doses. So then the thought process that probably a single priming dose is enough, and we probably don't need to give more doses of an anti-CTLA4 monoclonal antibody. Just one dose in the beginning is probably enough. That's how that thought process evolved. The baseline characteristics of all the arms were well balanced, including the sex distribution, the median age, Asia versus rest of the world, the etiology, viral versus non-viral, and in viral HBV and HCV, and the ECOG performance status, BCLC stage B, unresectable versus stage C, and also the ALB grade, Child-Pugh classification, all these macrovascular invasion, PDL1 positivity, AFP value being 400 or more, all these characteristics were very well balanced between the two arms. And patients who tested positive for HBsAg or anti-HB core antigen with detectable HBV DNA, HCV patients who tested positive for HCV or had a history of HCV infection, these were the ones who were actually considered as viral positive, and only then they were put under the category of viral related or viral etiology related HCC. The primary objective is overall survival for the T300 plus D arm versus sorafenib. The primary endpoint was met where the median overall survival with the tremelimumab durvalumab arm was 16.4 months versus 13.8 months for sorafenib. So that is a difference of about 2.6 months with a hazard ratio of 0.78 and confidence intervals less than 1. So two-sided p-value was quite significant, 0.0035. So if you look at the 18-month overall survival, it was 48.7% versus 41.5%. The two-year median overall survival, the two-year overall survival rate was 40.5 versus 32.6%. And if you see the curves are gradually, the separation is getting wider and wider. And at the 3-year time point, the overall survival was, there was a 10% difference in the 3-year overall survival of 30.7 versus 20.2 months. So definitely the primary endpoint of the study was met. It led to a statistically significant about 3-month overall survival. The median overall survival benefit was seen with tremelimumab 300 and durvalumab combination as compared to sorafenib. The hazard ratio for time up to 9 months was 0.87. And after 9 months, it was 0.7. So this is what that even at 3-year, the overall survival benefit was maintained. So if you look at the 4-year OS update stride regimen versus sorafenib, if you look at that, the 4-year update, this is 25% versus 15%. So the OS rate ratio was 1.67 and the median OS 16.4 versus 13.8, p-value of 0.0037, which was statistically significant. The median follow-up duration between both the arms, the stride regimen as well as the sorafenib regimen, was almost similar. So there was a 10% 48 at the 48-month time point, there was a 10% difference in the median overall survival. If you look at across the subgroups, most of the subgroups, there was the plots were in favor of the T300 plus D arm as compared to sorafenib. So irrespective of the sex, the age, less than 65 or more than 65, the region Asian versus non-Asian, the viral etiology, especially if you look at the hepatitis B, the entire population is on the side of T300 plus D. And ECOG performance status, irrespective of that. BCLC, again, the BCLC-C, it kind of showed to be more in favor because for BCLC-B, the population is crossing the line of unity again. Macrovascular invasion, not present, they did a little better. So, and AFP, when it was more than 400, again, that entire population is towards the tremelimumab durvalumab arm. PDL1 status, it really didn't matter. So across most of the subgroups, if you look at the hazard ratios, also most of the subgroups and the confidence intervals, if you see, many of these subgroups, they had a significant benefit with tremelimumab durvalumab as compared to sorafenib. The 4-year OS by etiology, when it was assessed, that is all participants, hepatitis B, hepatitis C, and non-viral. As we had seen in this forest plot also, with hepatitis B, there was a maximum benefit actually with the tremelimumab durvalumab arm. So the viral etiology, especially the hepatitis B, even if you look at the hazard ratios and the confidence intervals, are very significant here. And again, overall participants also, if you see, they are more in favor of the tremelimumab and durvalumab arm overall, and predominantly probably driven by the hepatitis B. So another important difference between the IMPOWER trial as well as this Himalaya trial is that the NASH, if you look at the baseline characteristics, the viral etiology patients, they constituted about almost 50 to 60%, whereas non-viral etiology was almost 40%. So this number was much smaller. It was mainly a viral etiology population there, and non-viral like NASH related, which is very common in Asians in our part of the world, is it was a little less represented in the Atizo-Bev trial. The OS improvement with STRIDE in non-viral etiology subgroup, it was similar to the full analysis set. So the non-viral etiology, because there is conventionally, there is an opinion that immunotherapy-based regimens in HCC, they work better for viral-related HCCs rather than the non-viral related. But if you see in when the non-viral etiology subgroup was analyzed separately, the OS benefit was still there. Like the 3-year OS was 31% versus 12%. So this is a very big difference of almost 19% difference in the OS rate at the 3-year OS rate. And the 4-year OS rate also, it's 25% versus 8% in favor of the STRIDE regimen. And so this is something which is very significant, because a significant benefit has been demonstrated in non-viral etiology. This is much more relevant in Indian subcontinent because NASH is a very common problem here. And if you look at the full analysis set, and this, it was very much maintained when the non-viral etiology was analyzed separately, the OS benefit was maintained just like in the full analysis set. So this is a very important point. And the secondary objectives included the OS difference between the durvalumab alone, 1500 mg durvalumab arm, and the sorafenib arm. The median OS was 16.6 versus 13.8 months with a hazard ratio of 0.86. That just crossed the point of statistical significance. So the 3-year OS still numerically, if you see, it's not a very big difference. It's maybe about 6 to 7% difference at the 18-month time point, the 2-year time point. And at the 3-year time point, it is about 4%, the difference in the OS between the two arms. So addition of tremelimumab definitely widened this OS difference and this OS benefit, which was seen. Definitely with the addition of tremelimumab to durvalumab, it did make a lot of difference. So the hazard ratio up to the 9-month time point was 0.98, and after the 9-month time point, it was 0.77, which is somewhat significant. But overall, if you see the median OS, again, the hazard ratio was 0.86, which is quite impressive. So the OS hazard ratios for STRIDE versus sorafenib in the ALB grade 1 versus grade 2, grade 3, they were consistent with the full analysis set. So ALB grade 1 also, there was a survival benefit with the OS for hazard ratio of OS being 0.79. And grade 2, grade 3 ALB score patients also, they had a OS hazard ratio of 0.83. So in both of them, both these categories, the survival benefit was seen and it was maintained with the STRIDE regimen. Both of them behaved similarly, just as the full analysis set. Then one of the secondary endpoints was again the progression-free survival of the STRIDE regimen versus sorafenib. The median PFS of the STRIDE regimen, it was 3.78 months as compared to 4 months, but this difference was very small and it was not statistically significant. The PFS for hazard ratio was 0.9, which was again not very significant statistically. Progression-free at the time of analysis, about 12.5% of the patients only were progression-free at the time of the final analysis, that is at the data cutoff. And the median time to progression was 5.4 months. So treated for 1 cycle and beyond, almost nearly 50%, nearly half of the patients were treated for 1 cycle and beyond with this regimen. So PFS benefit, we can say maybe it's not a very big PFS benefit that was seen as compared to STRIDE regimen as compared to sorafenib. And the tumor response rates, if you see the overall response rates, 20% with the STRIDE regimen, 17% with durvalumab single agent, and only 5% with sorafenib. In that, about 3% of the patients had a complete response with the STRIDE regimen, whereas there were no complete responses at all with sorafenib. That is something which is very significant. 17% of the patients had a partial response, only 5% of the patients had. So whoever responded, the 20 patients who responded to sorafenib, which is just a 5% response rate, they all only had partial responses. In more than half of them, it was a stable disease, whereas stable disease was seen in about 40% of the patients. And progression was seen in almost similarly 40% and versus 39% of the patients. The duration of response, the median duration of response was about 22 months as compared to 16.8 months with durvalumab and about 18 months. So definitely the duration of response was also longer with the STRIDE regimen as compared to sorafenib. The median time to the tumor response treatment response was about 2 months versus 2 months. So 2 months both with the STRIDE regimen as well as durvalumab single agent, and with sorafenib it was about 3.7 months. So definitely the overall response rates were much better, much better with the STRIDE regimen, and even with single agent durvalumab also quite a good overall response rate of 17% as compared to sorafenib alone. It was a good response rate of 17%. If you look at the safety and tolerability, any adverse events were seen in almost all of the patients. Even with sorafenib, that number was quite high. With durvalumab alone, it was somewhat better. It was about 89%. And grade 3, grade 4 adverse events, if you see any grade 3, grade 4 adverse events, almost 50% of the patients had grade 3, grade 4 adverse events. Again, that number is smaller, about 37% only with durvalumab. Even with sorafenib, more than half of the patients had grade 3, grade 4 adverse events. And serious adverse events, any treatment-related serious adverse events were seen in about 17% of the patients in the STRIDE regimen arm as compared to 9% in the sorafenib arm and 8% in the durvalumab arm. Grade 3, grade 4 hepatic adverse events were seen in about 6% of the patients in the STRIDE regimen arm, 5.2% in durvalumab, and 4.5% in the sorafenib alone arm. And any immune-mediated adverse events that required high-dose steroid treatment was seen in about 20% of the patients. They were not seen much with sorafenib arm because this is not an immune checkpoint inhibitor therapy, not an immunotherapy. Basically, about 2% of the patients had some events, and it was seen in about 9.5%. So if you compare STRIDE versus Durva alone, definitely there is almost doubling of the immune-mediated adverse events requiring high-dose steroid usage. And requiring study drug discontinuation was seen in about 5.7% of the patients in the STRIDE regimen arm, only 2.6% of the patients in the durvalumab single agent arm, and about 1.6% of the patients on the sorafenib arm. So these were this was the adverse event profile, and it was the numbers were quite acceptable and manageable. Treatment-related hepatic or hemorrhage related events. So patients who had hepatic events, so this is the standardized median DRA query. So this is a statistical parameter, and the drug-related adverse events. So if you look at the treatment-related hepatic or hemorrhage events, it was seen, all grades were seen in about 17%, grade 3 or more in 7%. Hemorrhagic events were very, very rare, only 1.8 versus 0.5. Grade 3 or more is 0.5. Overall incidence of hemorrhage was only 1.8%. With sorafenib, the hemorrhagic events were a little more, 4.8%, and grade 3 was seen in about 1.6%. The hepatic, that is hepatitis, and the liver-related immune-mediated adverse events or liver-related events, if you see 17% versus sorafenib 12.3%, grade 3 7% versus 4.8%. So still it is a little higher, the hepatic related events, which included many of these parameters like transaminitis, bilirubin increasing. Patients going into hepatic encephalopathy were not seen at all with the immunotherapy arm. Ascites was seen in just one patient. Transaminitis, yes, a good number of patients had transaminitis. Esophageal variceal hemorrhage was not seen with any of these arms, neither with sorafenib, nor with single agent durvalumab, nor with the STRIDE regimen. And INR increase also was seen with very few patients. So this overall suggests a very acceptable toxicity profile that we are talking about. And the immune-mediated adverse events in the Himalaya trial, the overall survival by the immune-mediated adverse events. Just give me 1 second. It's showing the low charge. Just 1 second. So the immune-mediated adverse events in Himalaya trial, when overall survival was analyzed as per the immune-mediated adverse event occurrence in the STRIDE regimen, if you analyze, the blue line is the patients who have developed immune-mediated adverse events. The black line is the patients who have not developed the immune-mediated adverse events. When this was analyzed this way, the overall survival was better in patients who actually developed immune-mediated adverse events. So if you see 23.2 versus 14.1 months. Now, this is not a pre-specified subgroup category that they didn't specify prior that they would be analyzing in this way, but just as a thought-provoking thing, when this kind of analysis was done, it was seen that at the 3-year time point, it is 36.2% versus 27.7%, the overall survival, and the median OS is also almost 9 months longer in patients who developed immune-mediated adverse events as compared to those who did not. And the hazard ratio, the OS hazard ratio was 0.72, which was actually statistically significant. Although this is not, again, a pre-specified subgroup analysis, but this is a very interesting thing that those who had immune-mediated adverse events, they had a better overall survival. So this is the STRIDE regimen. And if you look at the OS by immune-mediated adverse event occurrence for durvalumab, there was not much of a difference. You can see the graphs are on top of each other, whereas here they're actually separating early and the separation continues even at the 3-year time point. So with Durva alone, this kind of a picture or this kind of a trend we did not see with Durva alone. So probably those who develop immune-mediated adverse events with the anti-CTLA4 and anti-PD-1, PD-L1 combination, maybe they do better, they have better anti-tumor responses. That is what we can conclude. However, it's probably not significant enough because this is again an unspecified subgroup analysis. So if you look at the key takeaways from the Himalaya trial, the IO-IO combination of STRIDE regimen that used tremelimumab and durvalumab, this is a new option in the first-line treatment of HCC. Overall safety profiles were consistent with the known safety profile of each regimen. Events were manageable as per the treatment guidelines. The STRIDE regimen of tremelimumab, durvalumab also has shown an equal overall survival benefit with an impressive 3 and 4-year OS rates. Consistently, the OS difference between the study arm and the comparator arm was maintained even at the 4-year updated analysis. So they're in favor of the IO-IO combination. Both STRIDE and Durva monotherapy had manageable safety profiles globally, with low rates of grade 3, grade 4 treatment-related adverse events and treatment-related adverse events leading to discontinuation of sorafenib, and no increase in liver toxicity or bleeding risk. The risk of liver toxicity, hepatic toxicity was also quite acceptable, just in single-digit percentages, and bleeding was literally not seen at all as compared to the atezo-bev regimen, where quite a few patients had significant bleeding events. Exploratory analysis support the use of STRIDE irrespective of the underlying viral or non-viral etiology. That also we've discussed that in the non-viral etiology, when they were analyzed for OS separately, the patients with non-viral etiology, they also did quite well, and their OS graph was very similar to the overall population OS graph. The baseline ALB grade irrespective of that, adverse event profile, and also irrespective of the part of the world to which the patients belong, Asian versus non-Asian, they all benefited. Thank you very much. I'm happy to take any questions.
There is a question in chat box.
I am actually not able to see. Can you just read it? Yeah, now I can see. Sorry, I'm sorry about that. Yeah, that's right. As Arif sir has said, like in patients who have a high bleeding risk and especially NASH related, because that population was better presented here. Response rates in almost Shikhar has written response rates much lower than the expected with tremelimumab durvalumab. Yeah, response rates, yes, still it is quite low, but compared to sorafenib, it's better, that's all. And almost 30% overall response rate with atezobev. Yeah, the response rates, maybe bevacizumab probably played an important role over there, I can say, in adding to the better response rates over there. Arif sir, what is your opinion about that? Do you? I think bevacizumab had a role to play in that regimen having better response rates, right?
So both are very good regimens, I can say.
Yes,
There's nothing much to choose
yes,
between them because
yes,
these were not powered to see at that subgroup.
correct. Yes,
But we can say we can just because for the practical management, we can think that bleeding risk is very much high in these patients because
in the
CFP,
atezobev regimen, yeah, with these
yeah,
patients, yes,
we
yes.
need to think about that.
The
And
fact that
more,
bleeding events are almost
yeah.
nil with this regimen is something which adds to the safety.
Probably not get a clear-cut answer because you can't we never get head-to-head comparison, but
Yes, correct. Yeah,
we can say that with bleeding risk and with the NASH related, we see quite often, that non-viral patients are more rather than the viral patients. So in non-viral and
yes,
what I think that's in my view. Yeah.
yes, yes. I think on a patient-to-patient basis, we probably have to decide.
Yeah, yeah.
Yeah.
Thank you once again, Monica. That was a very excellent presentation. You have given a very elaborate discussion about the tumor and immune cell interaction and also walking us through the every inch of the Himalaya trial. We know what is Himalaya trial now. Thank you once again for an excellent presentation. Now we move on to our next topic. We have a case-based panel discussion for which I invite Dr. Rakesh, the senior medical oncologist at Indo-American Hospital, Dr. Shikhar Kumar, again a consultant medical oncologist at Yashoda Hospital, and also Dr. Kripa Bajaj, consultant medical oncologist at KIMS Hospital. So let me share my slides here. I think my slides are visible here. Vishal, are my slides visible?
Yes, sir.
So Dr. Rakesh, Shikhar and Kripa, are you there?
Yes, sir.
Yes, sir.
So first we'll start with the HCC. I'm going to present this case here. 54-year-old gentleman who present with pain abdomen, loss of appetite, loss of weight. He was having CLD with portal hypertension, which was probably NASH related, did not have any viral etiology here. EFP was around 1002. PIFCA, we do it in all patients here in our center, 2081. It's quite high, and bilirubin 1.6, albumin 4.7, INR was pretty much controlled, no ascites, no hepatic NCAF. So child PUA, we started with MRI liver. It's a very large HCC as such, 11 centimeters, occupying the segment 4, segment 8, with extension into the segment 4B with tumor thrombus in the main portal vein almost extending to the splenoportal confluence. So it was LR5. We did not do any biopsy. It was pretty much conclusive that it is HCC. We've done a PET scan again to see the distant staging. So no meds here. So how would you like to proceed? I will start with Dr. Kripa here. Kripa?
So actually, like to say AFP as well as the imaging evidence of like early washout in the venous phase has to be like confirmed. Though MRI is like saying that there is no need of doing any biopsy right now in the HCC, because we know that imaging
Right,
itself says that it's HCC. So once
right.
it got confirmed by the CT scan, triphasic CT scan,
Mm,
because looks like it's a unresectable hepatocellular carcinoma, and also it's a NASH related one.
right.
So, like Dr. Monica Madam just discussed now, in this one, as per the patient, like I would like to see the varices and everything in the baseline, so that patient will not decompensate, not to offer bevacizumab, not for bevacizumab, but for the total holistic care of the patient. Later, I would like to offer IO plus IO combination or lenvatinib as per the affordability of the patient.
Patient is affordable and there are no varices. So pretty much controlled liver disease. IO, which one would you prefer, Dr. Kripa? So we are
So,
two options now. Yeah.
yeah, sir. Durva plus tremelimumab has a longer data compared to other IVO combination like Nivo EP. So, I would like to offer Durva plus tremelimumab, sir.
Okay. We will offer Durva Tremi for this patient. So, Dr. Shikhar,
Yes, sir.
so what will be your next step here? Because there is a venous invasion BCLCC. We know that it's out of the curative option and still localized involving the portal vein. You'll consider some local treatment in this patient or straight away move to systemic.
No, sir. I think all the data that we have, there is no definitive role of any local treatment in this. This is main
Mm-hmm.
portal vein thrombosis. So as
Right.
Kripa rightly told, we'll do a upper GI endoscopy, band any varices if they are present. And since
Okay.
the patient is, having a child A, liver function is good, start the patient immediately on systemic therapy. The choice between atezo-bev and Durva Tremi is up to the availability and the individual experience. I myself
Mhm.
have never used Durva Tremi so far, but
Okay.
maybe with time we'll get experience with that regimen as well.
Yeah. Dr. Rakesh. Rakesh is here?
Yes, I'm here.
Yeah, Rakesh. How would you proceed in this? So local treatment any role or no? Just systemic.
So with portal vein thrombosis, I'm not totally looking forward for any TASE or tear.
Okay.
And I think it is right time to start systemic treatment. I think local treatments with 11 centimeters are not going to be very helpful. Even
Yeah.
ablation is not going to be very easy for this particular patient, deep-seated
Right.
10 centimeter tumor. So I think
Right.
if patient is fit enough, IO plus IO or Atazo plus BEV, both are valid options. And to an extent, probably we should also take an opinion from the transplant physician. The techniques are always evolving.
Mm.
Um, so
Okay,
yeah,
later on, if the downstaging is very good,
yeah,
then
if they are looking for any downstaging, are there opportunities down the line for a transplant is something that just want to prime them, not motivate them from that direction, but at least to take all the opportunities from the other consultations, other colleagues, so that there should not be any loose ends when we counsel the patients for such costly treatments. So I would
yeah.
agree with Dr. Kupa's overall assessment that this patient will deserve systemic treatment right away.
So again, we don't know much, but practically, your experience and which regimen would you consider? So we have got now two options, so which are available to us. The treatment still evolving. So Atezo Bev versus Durva Tremi, which one is your choice?
Um, I would say I have no practical experience with Durva-Trem. I've used Atazobev. So with that background, I would probably gravitate towards using Atazobev.
Okay.
Otherwise, Durva standalone treatment, if performance status is bit down, again, somebody who's young and really can take up some IO-related toxicities, then Tremi plus Durva should also be a great option. Looking at overall response rates and downstaging, maybe there could be some signal to go for Durva-Trem because there are better responses there. But otherwise, I don't know. I don't really differentiate both the combinations. Toxicities wise, yes, both are equally toxic.
Right. So based on the way, if the etiology, if you find, so based on that, you modify your regimen, NASH related or viral related. Do you consider these factors in deciding your treatment, or it's no, both are almost equal like, and you consider
Yeah.
any of the treatments?
Both have immunotherapy. Both are supposed to be doing, damage to the liver, and
Mm,
are going to having an effect on overall liver decomposition later. So
right.
having the hepatology team in hand, trying to
Yeah.
compensate for whatever they can. I
Mm.
think there is multi-specialty care is what is needed. I think I would probably go for atazobeb if there are no major varices in this patient.
Yeah, it
I
was
think
grade one or
um,
not addressed. So the grade one usually they don't band it. Maybe the just varices were not so high, not severe ones. Uh, so
if I
we
can
have
put a comment, sir.
yeah,
Uh,
Shikhar. Yeah,
I
Shikhar.
think I think one thing which is clear from seeing both the I am Brave data and now the Himalaya data is
Hmm.
patients who have viral etiology HCC,
Hmm.
patients whom I think now TKI monotherapy is now fairly outdated because you're seeing a
Hmm.
stark difference in the overall survival in the forest plots of these groups, although these are all unplanned subgroups, but at
Right.
least that is the best we have. And these patients should be counseled and motivated to take either of these two regimens rather than go for TKI monotherapy, which is still very widely practiced.
Yeah. Yeah.
Non-oncologists also like hepatologists and things like that.
Right. So that's brings us the next question. What percentage of patients go with immunotherapy in your practice? So, Dr. Kripa?
So right now in private practice, almost 40% of people are able to take immunotherapy, and still
Right.
60% of people are really not affordable for immunotherapy. So for
Mm.
them, I'm offering TK. So
Okay. Shikhar?
Sir, I think now with the newer PAP schemes, Atizo and it has
Mm.
become very attractive after the new PAP scheme. So I think
Yeah,
the number was definitely in the same ballpark. What Kripa told, 40 to 50% patients would take immune checkpoint inhibitors. Maybe even higher also. At the hospital where I practice, maybe it would be even higher than that. Maybe 60 to 70% would take immune checkpoint inhibitors.
good. That's a good number actually. Dr. Rakesh?
I don't have a lot of patients with paying
Mm.
capacity. At least in the RGC side,
Mm.
none of the patients will be able to take it.
Right.
The private side, probably, I would say three-fourths cannot take it and one-fourth can take it.
Right.
I think the sustainability of PAP program is what is going to drive the continuation of treatment in the last, in the one-fourth who can take also. So in overall, maybe 15%, less than
Okay.
20% can take the immunotherapy in the hepatocellular carcinoma.
Okay. Taken. So actually, these are not without any side effects. Immunotherapy has a lot of side effects. I have seen personally many patients going into decompensation. So, what is your experience, Dr. Kipa, after starting this immunotherapy? Because we are dealing with two diseases, maintaining the liver function and also the tumor itself. So, how many of your patients decompensate? So, whether you take into consideration the liver function before starting the treatment, how is it, Dr.
definitely,
Kripa?
sir. Definitely, certainly, I'll take into consideration of the liver function. Chalpugsi, I will not really do any heroic thing because the survival itself is very low. If I introduce Atizobev in viral etiology HCC, or here
Mm.
Durva plus Trevi also, the outcome is not going to be great and they decompensate eventually. Only Chalpug A and Chalpug B I try to offer, preferably Chalpug A. The people
Right.
who receive treatment when they are childbirth, the chance of going to decompensation is like very less. Like maybe they do survive at least for 14 to 18 months. Right now, two patients are with me. Both are doing really good. Childbirth B again, within 6 months they went into decompensation. C,
Mm.
I preferably don't offer this treatment at all.
Right. That's a very well point to be made. So, Dr. Shikhar, what do you see? I mean, liver function, is it your criteria in deciding the treatment, or what child you see the okay, the liver function is bad, but the PS is good. So, what do you consider in these patients? You will give some TKI or just supportive care? How is it, Shikhar?
No, sir. I think liver function is the single most important factor which determines treatment. C, as Kripa told rightly, it is only best supportive care, palliative care. I think from when I read the paper published by AIG and Vamshi's yourself, when I saw that, what the conclusion was that up till B7 is where the outcomes are still decent, where you have a median OS of 9 to 10 months. But anything 8 and above is very poor, if I'm not mistaken. So B7 is where till I would offer them atezobev or these dual immune checkpoint depending on the availability. But B8 onwards, it would probably be only palliative care and best supportive care. Maybe we don't have enough data for B8 and B9 separately, but I think that is what we should do.
Right, Dr. Rakesh, so liver function, deciding the treatment.
Yeah, I think liver function is both prognostic as well as to an extent predictive of the effect of systemic therapy also. And we can further dissect the liver function by doing something like RB grading, looking at how it can be optimized, trying to, get, hepatologist into the picture and getting his inputs on every monthly basis. So over and above, I think deterioration of liver function test, even in childhood A, based upon the clinical trial data also, we know that nearly 50% of the patients will migrate to childhood B over the course of treatment. Despite the responses to therapy, the liver function deterioration is relentless. So that has to be really put into our treatment plans. And coming to the treatment plan for a childhood B, yeah, anything beyond B7, yeah, absolutely. There is no indication for any dual combination immunotherapy or atezobev for any of these patients. But even for a B7, we need to take a lot of consents and we need to be well counseling the patients and their relatives regarding the realistic outcomes of these patients. Because I have treated such patients, and what I have noticed that the AFP comes down, but the ascites increases, the encephalopathy increases, the chance of variceal bleed increases. Despite all the supportive care that can be done, the liver function is going to really deteriorate over a period of time, and these people are going to succumb to liver failure. So counseling and consent form and being very careful with these patients is the need of the hour. I think childhood C, if you say that I have not come across as a childhood C patient who is having performance status, but if you say there is a good performance status childhood C, nothing more than sorafenib, that to 50% dose. And best supportive care is the standard line. But if you say he's a very young and which is, I mean, not practical, but if you say that, then probably 50% dose of sorafenib.
Okay, not lenvatinib, you will prefer sorafenib. Okay. So these are some of the data we know about these studies, Himalaya and atezobev. We need not go with this. So these patients, we have pushed our boundaries in this patient. Actually, the patient, we have done some heroic things here. So the patient received tear here in this patient with such a huge tumor. Later on, followed by we given SBRT to the PE thrombus. So that's how we have managed this patient. Because being a referral tertiary center, we need to push our boundaries, and maybe he would be eligible for some curative treatment. That's what we thought, and we are given tear followed by SBRT, then 5 sessions of atezobev as the consultation, again continuing the systemic therapy. The local tumor responded to this treatment actually. So there was shrinkage of the tumor and also the thrombus, but as we know that patient developed systemic meds, so lung meds. So progression after atezobev, SBRT and tear, then what next? Second line, what do you consider, Dr. Kripa? Lung
So
meds.
what is I'm just curious to understand. So this patient, like, what is the PFS you saw, sir, like with him?
So July 23, around when July he was diagnosed. So December around 5 months.
Right. Okay. Okay. Okay, sir. For him, certainly, like I would like to offer cabozantinib, sir. The second line, a patient performance status is like preserved, then I would like to offer cabozantinib because it's a multi-kinase TKI. Already the VEGF inhibitor as well as immuno got used. there is some data to use nivolumab single agent in the second line, even post atezolizumab, but which is really not strong to go into. With an aggressive progression within 5 months, I certainly would like to offer cabozantinib, and I am eager to understand the opinions from other colleagues as well here.
Dr. Shikhar.
Sir, probably it would be only palliative care. Looking at the
Hmm.
Tear, SBRT, and Atezo-Bev has not touched the disease. I don't know what anything else would.
Okay, Dr. Rakesh.
You are the tertiary center. You tell us what you have done.
Okay, I will tell later on what I have done with this patient.
Yeah, I would agree with both the panel members' opinion.
Uh,
Cabozantinib can be tried. It's a difficult drug. It has a lot of black box warnings. I get scared away from that. Palliative care is a pretty standard way of treating these patients, but patients always have, and the family always have more aspirations.
Right.
Yeah, but it is a difficult choice. If the child pook status is still A, then theoretically cabozantinib can be done.
Right. So any role of doing any molecular profiling, any in HCC, if you have done something looking for any targets, I have not personally done in any of the HCCs till now, but the data is coming up. So any experience, the panelists, Dr. Kripa?
So far, I
With-
didn't offer, sir. So far, I didn't offer anyone regarding the foundation medicine or something. But if our data, as you suggested, is coming up with some promising options, certainly I'll explore it, sir.
Roche, they are doing it. Any Shikhar?
No,
Anything?
sir, I have never done NGS testing on any HCC so far.
Rakesh?
Yeah, I haven't done. So once we had a combination of intrahepatic cholangiocarcinoma plus minus some HCCs, there was a confusion. So we did one NGS and there was IDH mutation. So we declared that was intrahepatic cholangiocarcinoma. But otherwise, a pure hepatocellular carcinoma with proper CLD, portal hypertension, I don't think so. We have enough data to suggest something changes in their treatment line.
Right. And still the data is still evolving here. The NGS is not what we consider in HCC, apart from all the tumors in other cancers. To decide the treatment at the second or third line, we usually consider NGS, but not in HCC till now. So these are the options available. Regorafenib, cabozantinib, all almost equal, but preferably we use cabozantinib. That is the preference what the oncologists consider in the second line. We have got ramucirumab, regorafenib. It's a hard drug to tolerate, regorafenib. Again, ramucirumab. I don't have much experience with this. So we can use, as Kripa told, that there's some, these were all post-sorafenib era trials. So some data coming up with after immunotherapy, but still in the evolving stage right now. So this patient we use cabozantinib, as Rakesh wanted to know. There were again increase in the lung meds after 4 months. The patient was actually in a very bad shape after progression. We did not offer any other treatment. So if the patient performance was better, so any re-challenge with immunotherapy, Dr. Kripa? So
I
cabozantinib,
certainly will not, yes, sir. I certainly will not offer post 2 lines, third line immunotherapy, sir, unless, I mean, I don't see any point of offering IVO at this point.
Okay. Shikhar?
I agreed, sir. Agreed with Kripa.
Rakesh, anything you
So
want to add?
just to touch upon the theoretical advantage of rechallenge, that is something that has been tested in melanoma, it has been tested in lung cancer as well as in renal cell cancer. Potentially, the factors that would give us at least give us a fair chance is where where there is a gap between initial attempt at immunotherapy and rechallenge should be at least more than 6 months or at least 4 months. And because there's a patient who had toxicities and had to stop the drug, an intervening period they have taken some treatment and had a preserved performance status. I'm saying this is for the lung cancer. Then we can re-challenge the immunotherapy with some additional anti-immunosuppressive medicines like mycophenolate, mofetil, some steroids and something like that. Even then, it looks like the responses are only 50% of patients who go for rechallenge. And those patients who had progressive disease and immediately challenged with immunotherapy has absolutely no benefit.
Right, right. Is need to have some benefit, some PFS before rechallenging it. Personally, I have not used this, but the experience differs and rechallenge. But if you don't have exhausted all the options and the patient is still willing for treatment and is in good shape, then we can try these things out. But we really don't know what to be done in the third line as of now.
So if this patient had a good at least intervening response to cabozantinib and maintained that response for at least a durable period of time,
Right.
Then he progressed, and then could be rechallenging with nivolumab, pembrolizumab with some amount of some backup of data. But immediately progressive disease and subsequent progressive disease within the span of 4 months, it's absolutely doesn't make any sense to rechallenge here.
Right, right. So this is again the new data coming up. This is in the first line, the checkmate 9DW. So again, Nivo EP versus Lenva. They have compared Lenva here with the other arm was sorafenib. Again, portal vein invasion was not included, main portal vein invasion as in the other studies. Some good data I can say, but not as promising as the earlier regimens like Atezobev and Durva-Tremi. Though Nivo EP versus Lenva 23 versus 20 overall survival, good hazard ratio 0.79. See the curves are crossing here. The Lenva initially they were doing better, Lenva sorafenib. After that, the immunotherapy picked up. Seeing the widening of curves after long follow-up, and the tail of the curves also showing maintained overall survival here. So these are the new regimens coming up. According to Shikhar, again the response rates 36 here, around 13% with Lenva. Those who are worried about the response rates and progression-free survival, so almost similar. So that's what we see even in the Himalaya. The progression-free survival benefit is not seen. We are seeing the overall survival benefit because these treatments need time to act. So once the patient shows some response, they show a durable response and improvement in the survival. That's how the immunotherapy works. So if it works in some person, it works very well. So we don't see many of the times PFS benefit with the immunotherapy combinations. We see overall survival benefit and improved responses. So we conclude with this, the HCC patient. Now we go on to the cholangiocarcinoma. So let's see this patient, 60-year-old gentleman, no comorbidities, so presented with jaundice. So initially some ultrasound done outside showing a liver SOL. We got a PET scan and a biopsy here. So segment 3 liver mass was around 4 to 5 centimeters, but it was extending into the adjacent segments and reaching till hilum. So there was jaundice at presentation and also invading the portal vein, having some peritoneal nodules, liver surface deposits. Bilirubin was 25, CN99 baseline was around 2200. Got MRCP to see the level of obstruction again. So it was having a segment 2-3 mass with a hilar stricture. It was a type 4 stricture. Despite PTBD was done to reduce the jaundice, the jaundice reduced, it came below 3. Then we tend to do actually the percutaneous biopsies are not so common in our center. So US guided FNAB was done from the liver SOL, which showed adeno-CA. Good performance status despite all the jaundice and all. He recovered after the stenting. The jaundice improved to less than 3 PS2. So what next? So metastatic cholangiocarcinoma intrahepatic, invading the hilum and all the major portal veins and also the left portal vein and peritoneal nodules. Jaundice decrease with stenting. Patient is PS2. So what next? Kripa.
So certainly this is a palliative case, sir, unresectable one. So this patient I would like to offer palliative chemotherapy. Preferably, like if the RFT everything is like fine, I would like to offer gemcitabine plus cisplatin based one. And durvalumab, I'm not really fan of durvalumab in cholangiocarcinoma, though everyone
Okay.
appreciates the data of durvalumab. So
Okay.
unless patient is really affordable, I certainly won't add durvalumab. Very affordable, extraordinarily affordable. And also, I would
Okay.
like to do some molecular analysis, the baseline regarding HER2, PD-1, MMR, IHC, all these things I want to do at the baseline itself
Okay.
to add a additional layer of treatment. So if ever those are positive, like HER2 positivity, I'm seeing right now in 8 to 10% of the cases they are positive. If ever HER2 positivity is there, I would like to add trastuzumab. If
Okay.
MMR IHC positive pan tumor, like we can add, we can give only immunotherapy also from our MSI is high or MMR unstable. So these aspects I do see before changing or adding a layer of immunotherapy to the patient.
Okay, fair enough. Shikhar, your practice,
Sir, I think
metastatic cholangio.
um, with all the flaws of the durvalumab trial notwithstanding, it is here to stay. And
Okay.
if you look at the forest plot, whatever data we have from the forest plot of both the Durva trial and the Pembro trial also, I think it's the intrahepatic cholangio group which actually had a better hazard ratio compared to the gallbladder subgroup, which practically had no benefit with the hazard ratio of 0.9 something. And the intrahepatic cholangio group consistently had a hazard ratio of 0.6 to 0.7. So maybe it is this group which maybe benefits by addition of immune checkpoint inhibitors. So if the patient's renal condition is good, as Kripa said, it would be gemcitabine cisplatin plus addition of durvalumab. At the same time, we don't know what to do with HER2 if it came positive in this setting, whether we should add it on top of this combination.
Yeah.
But we would send off probably a HER2 and MMR as a routine for all these malignancies and see how the patient responds.
Okay, in Tata, they are still doing a trial. The TAB 2 is still recruiting. We are looking if they had to positivity in biliary tract cancers to add trastuzumab or not. There's another one study going on. They're adding zanitumab and other with trastuzumab like that. Still, the studies are going on whether to add anti-HER2 therapy in HER2 positive biliary tract cancers. But Rakesh, what's your experience and how metastatic cholangio? How do you treat these patients?
I think whatever has been discussed, I would agree with that. And basically, it is a cancer that has no innovation since 2013, and the only innovation that we have is the two drugs, etoposide as well as the keynote trial 699, and
Right.
that is what we have to practice. And if somebody is looking at maintenance treatment as an option, then probably they should gravitate towards keynote trial. And somebody who is going to look at Durva, then they will just continue with Durva as a maintenance. And the absolute number, as I said, are
Okay.
disappointing.
Molecular profiling, what you do some NGS or just some HER2 and MMR to decide later on NGS. So molecular profiling, what you do? That you order some.
Yeah, if it is a liver biopsy and we have adequate specimen, then probably do
Hmm.
molecular profiling, which includes multi-panel NGS as well. But the
Hmm.
minimum panel that I would say is MSI testing as well as HER2 IHC.
Right. So bilirubin level, what we used to practice in Tata differently. So the what do you consider which bilirubin level you are comfortable to start the chemotherapy?
Less
Uh,
than 5.
Less than 5. Shikhar, you?
Sir, when I was doing my residency, we used to make it like three to four, not more than three. I think that's what we used to follow.
Right.
That's what we do now also.
Kripa, your any choice of bilirubin level when you start chemotherapy?
So certainly, like I see the velocity more, just like Dr. Rakesh mentioned, like 5, I'm also comfortable because 25 to 5 means it's a declining trend. When I was doing residency, like just along with Shikhar, we used to strictly put a cutoff of 3. But right now, I think 5 is also a flexible option. If the velocity of decline is like fine, it's good.
Right. So that's what. So next, immunotherapy backbone. We have two options now: Pembro and Durva. Really, how to choose one or the other? It's still difficult to say. But in some subsets we can prefer Durva because this benefit is almost similar in the trials. Even the hazard ratios are all quite similar. So survival improvement is also looks similar. We really don't know which one to prefer right now. So since the Durva was launched before, in our center we have more experience with the Durvalumab, Gemsys and Durva. That's what we consider. Then molecular profiling, we send off the NGS and also along with IHC with HER2 and MMR, PDL1 sometimes to so just to be sure that if something doesn't come positive, just to make us sure that PDL1 if it is positive, maybe this immunotherapy will work. That's what we think, but it was not a biomarker driven trial. So Topaz, we know about it. So around 2 months, 1.5 months benefit, 3-year update. So Delta is good. The curves are separating. Some improvement in the survival. As Rakesh said, since maybe 2-3 decades, we have not seen any new drugs coming up in this biliary tract cancers. So we see a lot of gallbladder cancers. Whether it works in gallbladder cancers or not, we don't know. But add-on therapy, those who are affordable, we can consider adding immunotherapy to the chemotherapy. So it worked in all subgroups. The gallbladder cancer, that benefit was less, as we can see here. And despite the molecular status, whatever it is, the wild type patients, so those having more wild type genetic alteration, no genetic alterations, they do well with this immunotherapy. Again, Pembro, again the benefit is quite similar, hazard ratio 0.8 there. Again, the curves are not much separating. That's what we expect in this aggressive cancer. These biliary tract cancers, we know that we are very aggressive. Even some amount of benefit is beneficial for the patients. And after we given 3 cycles Gemsys Durva in this patient responded well actually. We don't have the baseline scans, but the peritoneal nodules disappeared. And also, this patient had a significant shrinkage of the tumor. Continued 3 more cycles. After 6 cycles, he was still maintaining response, but after 6 cycles, he did not continue this treatment and he wanted to switch over to some other treatment because it was not affordable for immunotherapy by then. So, do you consider any maintenance apart from immunotherapy? Dr. Kripa, if the patient is responding, has shown response after 6 cycles, is no longer willing to take immunotherapy. That's what happens in our practice. So any maintenance treatment do you consider in this patient?
Yeah, sir. Like there is a once in 15 days schedule is there, which like have been like seeing and following from many centers. So with
Mm-hmm.
a maintained response, but only the challenge is gemcitabine will cause profound myelosuppression, which is a
Mm-hmm.
very difficult to do the give the maintenance of that. So if there is unless there is cytopenias are not profound, I think once in 2 weeks gemcitabine single agent is also decent enough to add on.
Mm-hmm.
So yeah, this is my take, sir.
Right. Any oral agents you do consider or just IV options? That's what you gemcitabine.
Sir, oral agents like I'm comfortable with capistrabine or S1, sir. S1 is
Yeah.
having a very good data in the intrahepatic cholangiocarcinoma as well as gallbladder
Uh-huh.
than compared to capistrabine. So and it's very well tolerated as well.
Mm-hmm.
So I think that's one option I will consider if ever I want to give oral maintenance. But there's certainly like just leaving like triple negative breast cancer or something, gallbladder cancer or intrahepatic cholangiocarcinoma, the PFS will be very less if we don't give maintenance.
Right.
So we certainly have to introduce some maintenance. Oral, I prefer X1 or capistamine. So
Right. 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 Shikhar, you are any practice, any maintenance after showing a
Sir, I
good
think
response?
most
Yeah.
by the end of 6 cycles, most patients will start progressing only. So I think the question maintenance is
Right.
itself a little bit unusual because what I have seen is by they have good response after 3 cycles, and
Mm.
invariably after 6 or 7 cycles they tend to progress. Is what I have seen in my practice so far. So probably by that time they anyhow they need second line chemotherapy with Folfox or Folfiri or whatever it is that we choose as second line regimen in these patients.
Okay, okay. Rakesh, so any maintenance do you consider if the patient still showing response and not affordable to continue the immunotherapy? So what do you practice something or just observe the patients and call and follow
I
up?
wouldn't call it maintenance.
Yeah.
And I wouldn't call it maintenance. I'll continue treatment as long as possible, as long as they tolerate it and continue to respond to it. As Shikhar was saying that 50% usually progress at the end of 6 cycles. Actually, the initial 3 months itself, a significant lot will progress. And after 6 cycles also, there is a continuous progress of diseases. And those who maintain at least a partial response or stable disease, they will continue on to receive the same drugs. I will not call it maintenance, continuation of treatment. And now we also have option of adding on immunotherapy. So that will also be added. And based upon tolerances, we can remove one of the drugs. Cisplatin can be stopped. Cisplatin dose is not that heavy in gallbladder cancer. It's only 25 mg per meter square, right? So
Right.
continuation of both drugs is also in fit patient, willing patients, it is feasible. Again, cytopenias are a problem, and we can increase the duration of the treatment. So, but having a continuous contact with them will give us an opportunity for second line treatments. If not, a very small number of patients are fit for second line treatments.
Right. Right. So he after
Sir, what's your practice at your center, sir, regarding post jumps to 6 cycles? Would you, I mean, if not durvalumab, like what is your preference to give maintenance?
So we are giving S1 here. So that's what we prefer. The gemcitabine we consider sometimes giving every 2 weekly or maybe 3 weekly like that. Otherwise, 2 weekly gemcitabine. Or the patient is not ready for the IV chemo, then we give S1. So majority of patients receive S1 in our center, and we have shown, though we are not analyzed the data and published it, but they maintain a good response with this treatment S1. So maybe 4 5 months additional will get progression free survival with these drugs. We have to head to analyze. We're collecting the data. Let's see what will be the PFS benefit we get with this maintenance oral drugs. So S1 I think it's a good drug to give. Toxicities are there, but very less as compared if you have to just titrate the dose. And many of the patients have a maintained response with this oral chemotherapy. So this patient had actually maintained a good response even after completion of 6 cycles for around 5 6 months. Then he came up again with the jaundice. Then his bilirubin was around 8. PET-CT was again showing increase in nomental meds, liver as well. He was actually a abroad patient, and he was very quite fit at even at bilirubin of 8. He was PS1, momental meds, and also new liver as well, small liver as well. Momental meds were not much increased, but some again liver surface deposits. So quite fit patient. Again, we got a stent, the stenting done. There was a blockage of the stent with the tumor. Stent was exchanged. Bilirubin reduced. So second line, what do you consider, Kripa, in these patients? GEM says,
Irinotecan based one, sir. So the irinotecan based capary or folfiri or S1 plus irinotecan if not used in during the maintenance.
okay, okay. So the all the guidelines suggest, even the NCCN suggests Folfox after GEMSAys. Do you have any experience of using again a platinum-based regimen after GEMSAys progression?
I have used for one patient, sir, but there is a significant neuropathy was there. So oxaliplatin, we know it's a severe neuropathy that too post cisplatin. As rightly other colleagues of mine mentioned that like we do have a very short PFS in spite of using maintenance.
Right.
So I certainly will not introduce oxaliplatin as a second line, sir.
Okay. Okay, Shikhar, your practice in second line?
Sir, the issue with the Folfox regimen was that it was compared against best supportive care. So that way, that trial was quite flawed. There was a lot of criticism regarding that trial. So I think from TMH, they have published the GB Select, I think, trial in which single agent irinotecan was non-inferior to Capiri, to Zelili. But that was predominantly a gallbladder cancer subset, is what we see. Then there's a Japanese trial which has shown that actually doublet Folfiri has done better than single agent irinotecan. So if the patient is fit and if we can give a doublet, we would give Folfiri. But if the patient is not willing for central line or cannot tolerate capecitabine, then single agent irinotecan.
Okay. So if the patient comes out to be IDH positive or something like that, we do consider chemo or some IDH inhibitors if the patient is affordable. That's what. We have got IDH inhibitors. So do you consider giving these inhibitors or you continue with second line? So what is your practice? What?
The toxicity profile would be more in favor of the IDH inhibitors, isn't it? Because irinotecan, in my experience, has never been easy to tolerate.
Right.
Profound fatigue, lot of alopecia, of course, is there, but fatigue and overall, it's not a very well tolerated drug. So I would probably tilt towards if you have a IDH mutation, for whatever benefit you have with the ivosidenib, I would probably give ivosidenib because of its better side effect profile only, mainly.
Right, right. Rakesh, your practice in second line in cholangios?
Yeah, invariably, most of them are not very good PS. So single agent irinotecan, either weekly or 2 weekly. And
Right.
definitely we will try to repeat a biopsy if it is feasible, do NGS, some targetable mutations are there. Definitely IDH mutations have better responses. PFS is anyway between 6 to 8 months with ivosidenib, but even with the chemotherapy is less than that. So if
Right.
there's option between both of them, definitely the targeted treatment will definitely be the first choice. But if there is no target, then probably single agent irinotecan.
All right, that's what we do in our practice. There's a target found better to give some targeted therapy. We had of all those patients we treat with cholangios, our experience is the mutation incidence, the genetic alterations are not so high. Maybe it gets picked up in less than 10% of patients. We have used this IDH inhibitor in one cholangio. A patient did not tolerate it, or maybe after 10-15 days the patient succumbed. So that's what, so these are not easy to use drugs. Even this IDH and FGFR for one patient had, but we did not use any targeted therapy for this patient. So IDH inhibitors are also not so good drugs. We have used most of these patients cholangiocarcinomas, they don't tolerate any of the drugs, and these are some of the molecular alterations which we find. It depends on extrahepatic versus intrahepatic cholangios. IDH is more commoner, almost equal incidence between extrahepatic and intrahepatic, and these HER2 mutations are also found. Some patients have FGFR2 alterations. We personally have not used any FGFR inhibitors, and these are some of the guideline recommendations to be used. The targeted therapies, if you find some genetic alterations which can be targeted, we know all about this. And I thank you all once again for the wonderful discussion here, giving your valuable insights to how to manage these patients, these difficult to treat cancers. So modality management is key in HCC and biliary tract cancers. We have seen later approval of these drugs, immunotherapies. We have quite a experience with durvalumab. Better if the patients are affordable and if they can take the treatment. So better to add some of the other immunotherapy to the chemotherapy to get the at least increased survival and outcomes. That's how we have gone through a fantastic discussion today about the hepatobiliary cancers. I thank you all again, the panelists, the speakers, everyone, for giving a wonderful presentations and giving the wonderful insights. And with this, we can conclude. Vishal.
Yes, sir.
So we have come to the end of the session here. So we can take some questions, or how's it?
So you can.
Uh,
So, sir, I have one query.
yeah,
Like,
yeah.
I was just reading about the Destiny pan tumor trial, which looked at HER2 positive cancers across all cancers. And to my surprise, I saw that even they took cancers of IHC 2 plus and 3 plus HER2.
Right.
Invariably, IHC 3 plus tumors across whether it was endometrial, colorectal, or biliary, they all responded well with Enhertu. But biliary with 2 plus also IHC, there were zero responses out of some 14 or 15 patients.
Low HER2 concept, yeah.
Yeah, so HER2 2+ also might not be a good target as far as biliary is concerned when you're trying to give it in
Right. But in breast it works. It may not hold true for other cancers.
That-
So we need to design some trials like that to see even in low HER2 apart from breast whether this N-HER2 works or not. So, we see that if the patient doesn't have that high expression of HER2, maybe this antibody drug conjugates, they don't work here. Yeah, right point. Right point. So, any other questions from the panelists or speakers?
So, sir, can we conclude?
Yeah, we can conclude this session. Vishal, you have something to say? Yeah.
Thank you everyone for your wonderful talks. Technical team, please close the meeting.
Yeah,
Good
good
night,
night,
everyone.
everyone. Thank you all for your participation and your wonderful insights. Good night, everyone.